Good morning and welcome. My name is Jed Byrne. I'm the Director of Global Health Partnerships at Health Education England. I'm absolutely delighted to welcome you to the first of our seminars hosted by Health Education England and the World Health Organization, which we hope will explore the importance of systemic workforce planning for strengthening the global health workforce. We're currently in the International Year of the Healthcare Worker, and at the service and sacrifice of millions of healthcare workers will testify the urgent need to invest in the global health workforce has never been more important in terms of health, in terms of jobs, in terms of economic opportunity, and in terms of equity. In support of this, Health Education England and the World Health Organization are hosting a series of 4 seminars which seek to discuss what systemic workforce planning is and how systemic workforce planning may be applied to develop workable and economically viable solutions to strengthen the global health workforce. Open to all, we want these seminars to generate discussion and debate within the wider global health community. And we're also joined today by a very special group of colleagues from 8 countries who are participating in a series of developmental action learning sets supported by HEE's partners, the University of Salford, to develop future expertise in workforce planning across the globe. This supports our desire to create lasting and strong communities of practice who can learn from each other and who can continue to develop capability and capacity. In the aftermath of COVID-19, workforce planning capability and capacity are both key in ensuring future sustainability in health services. And so cooperation and collaboration with each other will go hand in hand. This first seminar is largely introductory in nature and sets a context for the next 3 seminars. We will try to touch on what systemic workforce planning is and its potential contribution to strengthening healthcare systems in both theory and practice. We begin by focusing on workforce planning in the National Health Service, the largest universal health coverage system in history, which gives an English context and a UK context, with 2 of our 4 speakers coming from Health Education England itself, the executive arm's length body of the Department of Health, responsible for education, training, workforce planning and professional development. Within the UK, we've got a rich history of seeking to provide universal healthcare free at the point of delivery and centrally funded, and have sought to plan the shape of our workforce to support this. Clearly, our system hasn't always got it right. In fact, arguably, we've made every mistake under the sun. But that has given us a lot of lessons which we have learned from. And we have also had some successes which we're keen to share with our global partners. During this session, we encourage you to reflect on how you can apply some of these principles of systemic workforce planning within your own countries. Our second seminar in March 2022 will focus on the development of health systems over time and the challenge of responding to shocks that rapidly increase the demand on our healthcare systems, obviously COVID-19 being one of those. 2 further seminars will be held in the summer and autumn of 2022. We have a fabulous, absolutely amazing audience today of over 500 people attending from multiple countries. And just a reminder to our international colleagues, this seminar is being instantly translated into Russian as well. And if you prefer to listen in Russian, please press the interpretation translation button at the bottom of your screen. We're also recording this session, and the recording will be shared with yourself and others in the next few days. So, I'm delighted to introduce our speakers. The first, well, all 3 of them really need no introduction. The first is Jim Campbell, who since 2014 has been the Director of Health Workforce, the Health Workforce Department of the World Health Organization. He is widely recognized both as a champion and an expert in human resources for health. And his work at the WHO has included leading the development of the WHO's global strategy on human resources for health workforce 2030. Our second speaker is my colleague, Dr. Navina Evans, who since October 2020 has been the Chief Executive of Health Education England. Previously, she was Chief Executive within the National Health Service itself, being a long-standing leader in East London NHS Foundation Trust between 2016 and 2020. She's a psychiatrist by background with over 20 years of clinical experience in psychiatry, medicine, and paediatrics, as well as years of operational management experience. Our third speaker, Rob Smith, again needs no introduction, certainly not within the NHS, as he's seen as the godfather of workforce planning. He is the Director of Workforce Planning and Intelligence of Health Education England, and is frequently quoted as saying that workforce planning is not just a science, it's also an art. He's been in the NHS for over 34 years with a background in finance before moving into the world of workforce planning, and is the co-author of the first ever workforce plan for England, and 2015 led HEE's hosting of the 15th International Workforce Collaborative Conference. All three speakers, I'm sure you'll agree, have a wealth of experience, which I'm sure they will draw on in their presentations. And so without any further ado, I'd like to hand over to Jim. Over to you.
Thank you very much, Professor Jed Byrne, and to colleagues at Health Education England, and especially to fellow panelists, Dr. Nabina Evans and Rob Smith. It really is a pleasure to be working with the Health Education England, one of the largest healthcare systems in the world, as you heard from Jed, for universal health coverage, and with a wealth of experience in health education for healthcare professionals and others, and the workforce planning elements. And indeed, just to reaffirm our, since Dr. Nabina Evans has taken over as Chief Executive, the partnership with WHO really taking on board another stage of support and collaboration in the International Year of Health and Care Workers. So thank you all. Just a few points I was asked to make in terms of, you've heard from Jed the outline of the seminar series going into next year. Just a few points of where we are in the COVID-19 landscape as of today to set the scene. Next slide, please. Clearly, we've seen around the world the detrimental impact on the delivery of essential healthcare services, be that in prevention, promotion, treatment, community engagement, NCDs, sexual and reproductive health. A really, really significant impact as healthcare systems have had to face the shock of COVID-19, redeploying workers into the COVID-19 pandemic response, and therefore having to reduce the capacity to deliver services. Next slide. The overarching cause of which, from the member states who've been sharing information with the World Health Organization as part of these global public goods, is an insufficient number and capacity of the health and care workforce. Now, obviously, for workforce people and the 500 colleagues who are with us today, that's not a new lesson, but I think it really has, however, hit home again to many people in policy and planning, to many people in the delivery of essential services around the world, to politicians, to parliamentarians, that we are still, even with all the technology at our disposal, with all the innovation, with the digitization of health, nonetheless, a service that is based on people, a service that is based on the occupations, the professions, the support staff, the auxiliary, the water and sanitation, the hygiene, all part of a team of professions and professionals who are ensuring that the public have universal health coverage. Next slide. Those people, however, have been put through over nearly 2 years now, experienced the pressure of the pandemic like no other occupational group. They are having the impact on their availability, their health, their mental health, their well-being, and in their working conditions. And since the pandemic started, we've been collating global data on the impact. We've seen the estimated number of infections accelerating but decreasing over time as personal protective equipment, clinical protocols, risk management did kick in. However, unfortunately, we estimate more than 115,000 health and care workers have lost their lives up until the period of May this year. And with the Omicron variant now kicking in around the world, real consideration that more health and care workers will become infected in this process. Mental health, the stress, the burnout, the anxiety, all having an impact. Next slide. We know, however, that around the world, the significant element of running and delivering a healthcare services is in the education and employment of the workforce that comes forward. But we're seeing at a global level the public expenditure on health, total GDP, government expenditure into social spending, and then social spending for healthcare is now at a considerable risk. The World Bank, the International Monetary Fund, and many others are predicting that after the substantive investments into the COVID-19 pandemic, through public borrowing, through different debt configurations, is likely to have a substantive impact going forward over the next 4 or 5 years to see reductions in healthcare spending. This is at the same time as we have a workforce that is exhausted, where there is a backlog in healthcare services, where an immunization campaign for the first dose, for the second dose, and for any option of a booster dose in some countries is putting additional pressure on the same exhausted staff. And when we need to invest to ensure that equity and that the recovery from COVID-19 is a universal agenda, is demanding that we invest better as well as investing more. So some real considerations as we start to think about the detail of workforce planning is that the treasury, the purse strings may be tighter, and we're going to have to try and get greater effectiveness and efficiency and performance in the teams, yet with a workforce that is truly at a point of exhaustion in every health and care setting around the world. Next slide. The WHO, one of our key functions is to bring together evidence and data of what can work where, in what context, to really drive some of that agenda further forward. That evidence is applicable to the UK NHS, to many of the countries that are represented here together, low income, middle income, high income. It brings together what we believe are some of the critical actions that our planning and considerations should come together. We've looked, next slide and final, we've looked at exactly this. Member states this year in the International Year of Health and Care Workers requested in the World Health Assembly this year to bring together an overview, a strategic sort of set of actions that would have an impact in the next 8 years to recover from the pandemic, to ensure that we build on the health gains that have been made over the last 20 years around the world and really drive ourselves further forward for universal health coverage. And those actions, recognizing that every country will determine its best modality, but those actions brought together really in a simplified 3x3 framework, really around how we optimize, build, and strengthen the investments into health and the health and care workforce, their education and employment, and their practice environment. And the evidence says that if every country can really determine where they are in their particular situation, look at this and take forward some of the best practice that's available, our workforce planning can be both scientific in its response, but also very responsive to the population needs and the context of the country. That's the short overview of some of the big messages that we're looking at around the world. We look forward to this collaboration with Professor Jed Byrne, Dr. Naveen Evans and colleagues to really support each and every country that's looking at this challenge to identify and assess their own requirements and then go forward as best as possible through a multi-sectoral approach. Jed, back to you. Thank you very much.
Thanks, Jim, and thanks very much for taking the time. And I'm struck by the comments I heard you make last week about the tendency to verticalize healthcare and the obvious need, looking at what you've said, to make that much more horizontal and look at global leads. So thank you very much indeed. Can I remind all attendees that we're planning to have a 15-minute question and answer session at the end of once our three speakers have spoken. If you want to submit any questions through the chat box, please feel free to do so, and we will try and get these to our panelists. Thank you. Without any further ado, I'd like to introduce Dr. Naveen Evans. Naveen, over to you.
Thank you. Thanks very much. Thank you very much, Jed. It's a real honour to be able to speak today at this event, and how very timely and important at this stage in the state of health and care across the world. The International Year of the Health and Care Worker. And I think the first thing I want to stress is the words health and care. For a very long time, those of us in national bodies or in policy or planning may often focus on the health workforce, but really so much of our solutions. I can't believe your fire alarm is going off. I hope you can still hear me. I think it's a test. The health and care Jed, I wonder if we should go to Rob first, because I better check that this isn't real. Is that all right?
Vina, of course, yes, no problems at all. Rob, slightly earlier than planned, but it's the wonders of modern technology. Can I pass you on and ask if you could just talk to us for the next 10 minutes, if that's possible?
Hi, Jed. One of the aspects of workforce planning we're going to talk about is flexibility. So we'd better demonstrate it right now. Hi, everybody. My name's Rob Smith. I'm Director of Workforce Planning at Health Education England. And as Naveen said, it's a huge pleasure and privilege to be talking to you all today. And furthermore, I'm looking forward to working with you even more closely in the following seminars that we've got planned for the rest of next year. Just a bit of background. I've been involved in local, regional and national health and care planning, workforce planning for the past 20 years. But I'm also fortunate to have met and exchanged ideas with colleagues across a whole range of systems, both through our European collaborations and, as Jed spoke in his introduction, in the International Health Workforce Collaborative. And those shared insights are really important. And I think I was asked along here today to give you some insights and experience from our perspective. But as Jed has said in his introduction previously, some of that is through the mistakes we've made, as well as good practice we've developed. And I think as we go through this process, sharing some of those views will be incredibly useful, not just to yourselves, but also to us as we continue to grow our practice. The first thing I wanted to share with you is the extent to which, through the pandemic, the importance of workforce planning has become clearer to a much wider range of system leaders. Jim touched on it earlier with his reference to parliamentarians and others. And And I don't think I could understate how important having senior sponsorship from people who are normally outside of the workforce community is. There have been long periods of my life and my practice where this has been a niche activity. But the phrase I like to use now is that everyone appears to have become a workforce planner now. And we must capitalise on that for the good of our patients, community, services and staff. So that's certainly true in England, where the conditions of the pandemic and our positions as we came into that pandemic have created a lot of focus on what we do in the workforce planning space. But clearly that's also true globally. And the creation of the International Year of the Health and Care Worker is a perfect example that this issue is being acknowledged and accepted by people outside of the traditional workforce space. I thought it'd be worth reflecting just how that interest arose. Jim has talked it with some of his slides. But clearly in the UK, the major interest arose because it came clear really early in the first wave of the pandemic that workforce might be an absolute constraint to the delivery of services. And, you know, so we were sharing modelling into the incident response team that they were then using to decide on actions. And what became clear is that the amount of supply was always going to be finite in the shorter term. And you then have to start considering what are your options on the demand side. And that was both in terms of suspending activity, but all the way through to the actions to control the pandemic itself and the public health measures that were then taken. So you can see in its widest sense, workforce planning is part of that, an important part of that wider consideration. The other thing I think that has been clear is the extraordinary efforts that our health and care staff made and their flexibility. But the other thing that we've been stressing is that you can't rely on those extraordinary efforts in the longer term. They're simply not sustainable. So the upside is the appreciation of people's efforts and a focus on their well-being grew. The downside is the temptation to ask people to continue to do work. You know, we're now in the second year of a pandemic. We've got another difficult winter coming. But at least these issues are on the radar and agenda of our senior leaders. So that's workforce planning in the short term. This then led to clear reflections about the circumstances that led us to being in this position in the first place. We came into the pandemic with significant shortages across the health system. And the same senior leaders who are addressing that short-term problem have asked us to look at what are those conditions, what might we do in terms of policy changes that could create a more sustainable workforce future. The key point that came out of that has been a ministerial commission to Health Education England to look at a 15-year time horizon. So what might the future workforce look like? And then finally, again, in Jim's slides, he described the disruption to services that we've seen. And another piece of work that we're involved in is therefore to say, over the next 3 to 5 years, how do we recover those services and the unmet need that was generated during that period? And that medium-term planning is a very specific type of workforce planning that says we know what we want to achieve, we know how much work there's likely to be, we know how much money, even if that's less, as Jim has described, because of economic circumstances, or less more, and therefore what levers do we pull to make that work? And what I wanted to talk about there is not just that has raised significant senior sponsorship in each of those areas, but it also describes the complexity of workforce planning. You can see that we've talked about immediate period, very long term, and a medium territory. And some of the things we want to share with you both in this session and in future sessions is how we manage that complexity. Because it's not just about time horizons. We also need to make sure we can plan at different levels. So we have planning for providers, planning for systems, planning for regions, and planning nationally. And then there are colleagues who will also want to plan through different lenses. So they will want to plan for whole organisations or regions, but they will also want to plan for individual service pathways. So whether that's cancer services or mental health. And then other colleagues will also want to say, but what does that mean for my profession? What does it mean for clinical scientists? What does it mean for psychiatrists? What does it mean for nurses? So you can see that between the time horizons and these different angles to workforce planning is a complex beast. And one of the things we'd like to share with you is how we navigate that complexity. The first thing I would say is to name it. Make sure that those different aspects are understood by those new senior sponsors. There is a tendency to conflate workforce planning into a single activity, and as I've just described, it really isn't. The second thing we would say to do is to adopt a rational framework. Adopt a rational framework for workforce planning. In the UK, we use a 6-step process. It says scope the plan, make sure you have a service plan, find the workforce demand that goes with it, assess the workforce supply, and then crucially, develop an action plan using all the policy levers available to you and monitor it. The WHO and OECD have developed the labour market framework, which covers very similar areas. And in particular with the WHO, I like the fact that they even say, how do you adopt that framework, which is their 3D approach, which is data, dialogue, and decision. But I suppose we'll be discussing some of those in future sessions, but the key issue is to make sure you do adopt a rational approach. The landscape is almost too complex if you don't. So having said that, I think there are a couple of key principles that we would observe that whichever framework you adopt that you just need to keep an eye on. The first is to make sure that your workforce planning is fully integrated with your service goals. For too long, workforce planning is seen as a niche activity. You need to make sure that your service plans and your service goals are thoroughly tied into the workforce planning that supports it. In our area, we use the phrase more staff working differently in a compassionate, inclusive culture. And that final 2 points could easily get lost. You need to say that looking after our staff is a service goal in its own right. We're not being nice to people just to retain them. It becomes a service goal as much as delivering care to the populations you look for. The second key principle is that analysis and intelligence doesn't serve its own purpose. It's only useful if it drives action. The idea that you do a diagnostic of the challenge, but then don't act is just not acceptable. You have to have a clear line of sight to the fact that that you take action from your diagnosis and you pull the levers available. And that comes to our third point, which is what we observe is that it's rare that a single action can solve a workforce challenge. And therefore you have to act across all the levers and policy levers available to you. And the coordination of those levers is a fundamental workforce planning challenge because those policy levers are often held by different agencies. So we talk about using all levers at all levels. Our workforce planning effort is designed to try and make sure that we have an agreed approach to that action plan that solves the problem across all those different complexities of time and level, etc. So that's our framing for how we will want to discuss more detailed planning with you, including the Reaction to Shocks seminar in February. But I can't tell you how much I'm looking forward to doing that. As I've said, we've had extensive experience of working with other countries and sharing ideas. One of the key things we know that when we do that is that you have to have a deep appreciation of how the service system works in each country, how services are funded, how staff are employed and rewarded, and how they are trained and how that training is paid for, are fundamental building blocks when you take these general principles and these general frameworks and apply them to different countries. I look forward to working with you all in the near future. Jed, back to you.
Thanks so much, Rob. Very much appreciated and real food for thought. There was so much content in that, actually. I think I'm probably going to need to listen back to all of it, but thank you very much. So Navina, through a miracle, has managed to find another place to phone in because the fire alarm, I believe, was a real fire alarm, Navina. So could I hand back to you to continue your address? Thank you.
Thank you, Jed. And yes, apologies, everyone. I hope you can hear me and kind of see me. We managed to, I want to say thank you, a big shout out to the School of Social Sciences, History and Philosophy, who have allowed us to squat in their cafe for me to do this. So thank you very much. I think actually it's probably just as well I come at the end. I managed to catch some of what Rob said there, and also thank you to Jim for that introduction. It's the International Year of the Health and Care Worker. I think this is so timely that we are having discussions and thinking about workforce planning across the world, systemic workforce planning across the world. And it's really important for us to remember we're talking about health and care. And quite often we make the mistake of separating out health from all the other aspects of care, which contribute to good health and good well-being and good quality of life. So I think this is a real opportunity for us to think differently, not just in our own individual countries, but share across the world. Now, the importance of system workforce planning to the NHS in England, just to give you an example, a picture, I think over the years, we have always known how important system workforce planning is for delivering high quality, effective, value for money care for the population that we serve. However, it's been difficult, it's complex, and has many moving parts. But over the last couple of years, it's become so evident that this is something that we must do, and we must do well for the future generations and for the future of health and care. And we plan for the future now. Also, in the last couple of years, as demonstrated by my own experience just now, the world has become a much smaller place. We are much more connected to each other. We can share learning. We can share good practice. We can share how we can do things differently to benefit people. So the global health space is one that now have brought us all so much closer together. So this is a real opportunity for system workforce planning for us in the NHS in England. It is important to remember that this starts from communities and then maybe to larger places, to cities, to towns, to countries, to regions, and across the whole world. At the heart of all of this, I would say this, wouldn't I, being health education, education and training is really important. It is important to make sure that we keep up to date with what our populations need and that we train and educate the workforce of the future with that in mind. So education and training is intricately linked to workforce planning, cannot be separated, and please let's not separate it. It also means that there's a challenge to the way we educate, train, and plan. We need to learn from how we've done things in the past, what has gone well, and what needs to be different going forward. So it's not enough to just think that we train in a particular way to develop very high quality workforce of this particular sort, and this is what we're going to deliver in the future. I think our populations and our people deserve and demand more than that from us. The mutual aid benefit of collaborating and learning from other countries with new ideas which we can all exploit in the future. There's a long history of mutual aid and benefit for all of us across the world, especially those of us in this group today. However, I think it's time for us to take that to the next level, that actually there's a lot more to share and a lot more to learn. And one of the things that I would like to focus on is to think through, and I would ask your help, what are the barriers and obstacles to really developing and sharing learning across the world? And when we identify those, we don't let them stop us, but we turn them into our task list, our to-do list. The UK has I think, a particularly important role. in terms of developing the global workforce. And I think that we need to step up and do the right thing. It doesn't mean that we have to, it's not just about investing in financial terms, but it's also in terms of supporting one another and investing in what we already know and how we can share learning materials, methods, and lots of other intelligence and the benefits that we have. The role of Health Education England, I think, is one where we can act as a convener, we can bring partners together, and we can also support learning through how we deliver the health service in England. We, of course, also have responsibilities for the 4 countries in the United Kingdom around training and education, and we can also bring that expertise to bear. So with all that in mind, I think that we've got a real fantastic opportunity, and this is the first of the seminars that will enable us to develop them further. I have an ask of all of you. I would like to get from this work maybe some ideas about some concrete collaborative opportunities for us as we move forward in this global space of learning, development, workforce planning for health and care for the future. Thank you, Jed.
Navina, thank you very much, and apologies for the distress of having to move position. I'm just trying to process everything really that's been said. I wonder whether it would possibly be possible to have the 3 panel members with their videos on, so we can maybe look to having a bit of a Q&A. There've been quite a lot of questions in the chat box, and with the help of some colleagues, just want to try and take some high-level questions. But can I commit to anybody who does ask a question in the chat box that the Global Technical Collaboration team will endeavour to answer those questions as best as they possibly can, or introduce the right connections as required. So please feel free, and if we don't get to your question in this session, we'll either answer it at a subsequent seminar or write to you directly. I suppose just following on what you said, Navina, given the importance of care settings in managing COVID, and thinking about the neighbourhood focus and family focus, and even social care focus, how can we ensure that care is placed at the centre of workforce planning, which is traditionally, I guess, focused on healthcare?
Shall I start, Jed?
Yes, please, yeah. Navina, if you want.
Yeah, so there are 3 things that I think are really important. And for all of you workforce planners in the audience, I'm not one, by the way, is to stay really connected to the populations that we serve. So I would love to see for us to really understand the populations and build our planning from place inwards. So that would be the main thing that I think that we could really do differently. The second thing is that what's already working well. We hear so many wonderful stories of things, great initiatives around the world, and in the spirit of continuous improvement, we really must step up and do better in picking up and spreading what's already working well. And then the final thing is, I think there's so much that we can benefit from by really connecting. So the word collaboration. Quite often we do these things in silos, and collaboration does not cost a lot.
Thank you. Rob, do you want to come back on that?
Yeah, look, some of our phrases can be quite abstract, saying let's integrate this with service planning. Navina's just described what that means. If we plan for the wrong services or the wrong approach because we're trapped in it's about the hospital or whatever, then workforce planning is always going to fail. The key point we're making when we say let's integrate it with service goals is that let's get to the community, understand what they want, and then plan for the workforce that can deliver that, not what can deliver some paradigm you might hold yourself. But that remains true wherever you start. If you start trying to plan your workforce without being firmly connected to what your system and service wants to deliver, you're on a hiding to nothing from day one.
Thanks, Rob. Jim, any thoughts on that?
I think, Jed, what we're seeing around the world more than 1 in 4 ministries or departments responsible for health and care have specifically got a title which is around health and well-being, health and welfare, health and care. More than 1 in 3 have a mandate to integrate health and social care services. So whereas we've seen this in the UK more recently, this is an expansion globally. And I think we're going to see in the next 2 to 5 years a real acceleration in integrated health and care planning as a necessity to respond to population's needs.
Do you see, sorry, to come back on that, Jim, do you see technology as playing a major part in that integration, particularly in low, middle and emerging economies?
Absolutely. I think technology and digitization is offering us an additional set of tools to consider and how we utilize those for service delivery, service management, service financing, and no different and in education as well, and virtual supervision, clinical support. So it's going to have an impact. I wouldn't necessarily say it's going to overtake all the considerations of people. We still need to make sure our environment, the rights of the workers, their pay, their terms and conditions, still the basics have to be done well. But technology and digitization will have a substantive impact, yes.
Thank you very much. So changing subject completely, well, not completely, but certainly a different tack. The 1920 saw the Year of the Nurse, and there was a tremendous momentum and groundswell, including the introduction of the Nightingale Now Nursing Now Challenge, a real enthusiasm and buy-in from across the globe, and the importance of nursing, midwifery, and latterly allied health professional activity in healthcare transformation. How do you think we maintain that momentum, Jim, in terms of making sure that the larger parts of our graduate workforce take more of a leadership and transformational role in the workforce and in planning that, of course, as we move into a sort of a post-pandemic world?
The last year, yeah, exactly, the Year of the Nurse and the Midwife, we published with the International Council of Nurses and other colleagues, Nursing Now, the State of the World's Nursing. We also published the State of the World's Midwifery. Jed, we have better evidence and data than ever before on the critical role of these occupations, these professions, the differences between the profession and their contribution to teams worldwide when they're educated, supported, and enabled to practice to their scope. They are a considerable added value to healthcare teams, and we're going to see that evidence slowly have an impact on policy. I think part of the challenge we're all going to see is how quickly can we turn evidence into practice across the world, and therefore we have to expand the leadership opportunity, education opportunity accordingly. Again, the evidence is overwhelming, Jed. Policymakers have to put that evidence into their planning, into their assumptions, their scenarios, and then deliver on it.
Thank you. Navina, do you want to come back on that?
Yes, thank you, Jed. I think the one thing I would say to add to what Jim has already said is that this is about making sure it's all of our business, it's everybody's business. It's turning what we've already learned into practice. And that's where service needs to really think about how we're going to do things differently to meet the demands for the future. So I suspect that we will also learn things this year around the health and care worker that we should be then thinking about how we're going to put that into practice. And that's all of our responsibilities, especially those of us involved in service delivery. Thanks, Jed.
Thanks, Navina. Rob, I'm going to try something slightly, or just put a slightly different tack on that. So, you know, the NHS has relied for its entire history on the international recruitment and migration of workforce, and Jim and the WHO have been very passionate about the need for mutual health system strengthening if migratory activity is to take place. How do you think we may better collaborate effectively on migration and recruitment?
Yeah, look, I think you start with making sure it's a conscious element of a wider all levers strategy. The reality is that the need for staff arises from new demand, long-term joiner and leaver rates, your domestic supply and international migration. You are able to act on all four of those domains, but over different time horizons. And I noticed that Howard Catton raised in the box that, which is, even if you're training more now, this is a quicker response. But it is the point to which you pull all those levers. You can control the demand. You can look after your own staff better to retain them. This is not a binary discussion that says it's either domestic supply or international recruitment. So once you've framed it in that way, then you can take a very positive approach to international recruitment, can't you? You can apply the right framings. You can make sure that this is something that's mutually beneficial to both countries. You can do all of that work. If you haven't got the rest of that framework, if it's just a reaction to a shortage, I think that's when you get the less acceptable faces of international recruitment. So this always comes back, doesn't it, to don't think you have a single magic bullet. It's here comes AI or here comes digital. Great, but be conscious of all of these levers, and in that way you can make your policy deliberate rather than reactive.
Thanks, Rob. Jim?
I agree with some of what Rob was saying. There are multiple areas of intervention for policy around the supply, need, demand, economic demand lens. And if we actually ensure that there's a much more integrated, multi-sectoral scientific dialogue, based on the evidence, we can start to untangle some of the strengths and weaknesses of different approaches to migration. Migration will happen. It's a phenomena that is with us for millennia. It will continue to happen. Health and care professionals are some of the most educated, tertiary, licensed, regulated in the world. They have choices in terms of that education, and there is demand. So it's going to continue to grow, but that doesn't excuse poor behavior. We can set good standards, and we can emulate good standards through a data-driven and dialogue process.
Thanks, Jim. Navina, again, just listening to everything that's being said, it seems to me that the NHS almost has an ethical obligation to use its learning for the betterment globally, and I think that was part of what you were saying. What practical steps do you think we need to? Because at the end of the day, I mean, even pre-COVID, there was a significant resource deficit, particularly in low, middle, and emerging economies, in terms of mobilising resource for health system strengthening. I guess one of the things that we're saying today is that if you're going to be systematic about developing universal health coverage, you need to have a systematic, scientific and artistic approach to workforce planning. So what would we do as a system, not necessarily HEE, but the NHS as a system do to act on that obligation to share what we know? What needs to be put into place, do you think?
Thank you, Jed. So there's a lot in that, isn't there? I think I will pick three main areas that I would like us to explore further. And I'll follow on from the conversation earlier about international migration, and the international workforce. That is an opportunity to share good practice, learning and values and behaviors. So I think that it's not just about we need a workforce, we're actually going to be learning something. So that's the first thing I think the NHS can do with our colleagues and friends who are coming from all over the world, is what are we learning as well. Then the second area for me is, again, coming back to improvement methodology and how we will benefit and share improvement in service delivery, not necessarily in evidence-based treatments. I think that's very well established, but actually in how we deliver services. Jed, you and I have talked before about frugal innovation, and I really think that that's something that we can be intentional about learning from. And then the third thing, I think, is as a system in the NHS, that we could and should have learning through global partnerships as part of how we want to make services better for the future and incorporate it into our workforce planning. So, Rob, I think that this, in terms of our work to develop our strategic framework for future workforce planning, there should be a thread, I think, in terms of what we're learning across the world.
Rob, do you want to come back on that? Thanks, Davina.
No, I agree. I mean, we often think we have some insights to share. We sometimes forget what we have to learn. But my experience from working both across Europe and with colleagues in America, Canada, and New Zealand is we're often facing similar issues. Now, let's be clear, there are other systems with different challenges. And Paolo, again, in the Q&A said, what happens when you haven't got some local capacity to do that? But you start by having a dialogue, don't you? And being humble that there is learning to be taken from different sources and keeping yourself open to that.
Okay, so Jim, let's reverse the question from the WHO's perspective. What would the WHO like to see the NHS doing in this space at the moment in terms of improving or encouraging others to mobilise resources on the health and social care landscape?
I think several layers for any G7, G20 country, and specifically given that the UK health and care economy, which is one of the world's largest in terms of the expertise that you have. We need to ensure that there is a global level commitment to invest in social protection, social spending, health and care, investments in health, on the wide social determinants of health, in prevention and promotion, and the public health functions. The emergency preparedness at an all-time, the demand for these all-time high. So we need to ensure that as part of the post-COVID recovery, that everybody is making sure that this burden is being shared around the world, and we're not reliant on out-of-pocket expenditure for people to access public goods. Secondly, then, within that framework, we have to ensure that the utilization of all available resources, and that's human resources and financial resources, is really maximizing the impact on people, on the patients, on the communities that we serve, so that we take every opportunity to engage, not vertically on one topic, but related to that person-centric approach to get forward. And therefore, the role for your expertise in the UK, in the NHS, in health education, and really to say what has worked for us, what can we share, but also what else is working to really drive this agenda. We need the data. Our program around health workforce information and the reporting on health workforce information is still not robust enough globally, and we need to do better on that. Use that then across health, education, care, labor, gender. So many of our workers around the world are female, that we're really bringing together different sectoral expertise and drive investments that come together at that level. So this is, again, I just want to reiterate, Jed, how happy we are to be, sponsoring this work with Health Education England. The UK economy has lots of potential to help support us all in this particular moment in time.
Okay, so I'm just going to give them one final question, probably to Rob, maybe to Navina, and then ask Jim if he would do a 1 minute summary before we close. So the final question is this, and it comes really to the second point that you made, Jim, which is our experience working within a global footprint within those health economies, which are certainly the poorest or emerging economies, is that the planning around workforce is very much a generalist and distributed, or needs to be generalist and distributed, to generate a gradual bottom-up but all-inclusive universal approach to the development of health services. In a advanced system, which has been present for over 70 years, much of our focus, particularly over the last 15 years, has been on the development of pyramidal specialism, or sort of verticalization within verticalization, if you like. So my question initially is, what is the NHS's approach, or what would the NHS's approach be if it was starting again to develop a workforce? Would it create the specialist approach, or would it go for a much more generic, polyprofessional approach to developing universal health coverage? Sorry, it's a bit of a vague question, but I'm just trying to get to the nudge of how the NHS might help in this regard. Rob.
Yeah, thanks, Jed. I think that's called a hospital pass, isn't it? Look, we start where we are. I mean, that's one of the realities is of course the structure of medicine in those developed is what it is. I think what we're reflecting in things like our framework 15 is to say, can we start with what the population needs and work back from that? And if that challenges where you are, then so be it. It's also a thing that says, where would you want to be? It's probably both, isn't it? There are aspects of generalism and community practice and using the assets in a community, and there are still things where the deep knowledge of specialists and individuals, and it's not binary. And that makes it even more complex, especially when you're talking about now and the medium term and the future. I think that's where we'd start. I'd forgotten something that Jim just said, actually, which is we take the fabulous data that we have in the NHS for granted on workforce. We forget that other people don't. And in some ways, people would say you've still not done a great job, but we have regulatory data about who joins and leaves the register. We have employment data for 1.5 million people employed by the NHS, and we know how they move around. We know their characteristics. So we can observe and do lots of things. Where would you start if you were somewhere else? You'd have to choose your priorities. But that's my kind of general answer to the generalist question, but also we need to focus on priorities for data, as Jim has said.
Thanks very much, Rob. Navina.
Thank you, Jed. So in my view, I don't think is it a generalist or a specialist sort of debate. I think because we'll get stuck if we go down that route. I think that we need to, as Rob said, really stay close to what people want and need. And it's about creation of health and creation of well-being and creation of a good quality of life for everybody that we serve. The people have power, and people will not just, I don't think people will just let us kind of do what we've always done. So we've got a moment right now, and it's a real opportunity for us here in England and in the United Kingdom and beyond to think very, very differently for the future. And there are two things for me that we have to think about and grapple with collectively, which is that we, of course, will need more health and care workforce, but it's more and different. The more will be doing something different, and there will also be something different in the more, okay? I hope I'm making sense. And then the second bit for me is that I think we'll be thinking so much more about skills over roles, and that we will be developing skills to create health and to keep people well. And they will be delivered by the right people in the right place at the right time. That must be our ambition, and I don't think we should compromise. Thank you, Jed.
Thanks, Navina. So, Jim, over to you. 30 seconds to summarise what you've heard. That's a real hospital pass, by the way.
The key thing that I think we're getting to here is that any of our workforce policy and planning considerations, what are the services that are essential that have to be delivered, that benefit package, what competencies do we require in our workforce to bring that to the population we serve? And then within those competencies, what are the skill mix? What are the occupations, the roles that we need in our team? It is through teams. It is not through competition. It is not through the argument of a specialist versus a generalist. That is through teams that we will serve the populations in every country of the world. And that's got to be at the heart of our policy and of our politics and our investment choices. Thank you.
Thank you, Jim. Very much appreciated. All, thank you very much for your attention this morning. Thanks to our speakers who, my head is buzzing really, and there's clearly the question and answer session is buzzing as well. There are significant debates going on in the chat, which is great. As I said at the beginning, we're committing to using that chat and those questions that remain unanswered to stimulate the content of our next 3 seminars, but we will answer you individually as well. Many thanks to Jim, to Navina, and to Rob, to our Russian translators, who must have had a bit of a job on their hands, I think, over the last hour, and to the staff at the Technical Collaboration Unit in Health Education England. So thank you very much for your attention this morning. I think it's been a really great and very stimulating opening to this series of seminars, and I look forward to seeing you next time. Bye-bye.